Okay, great. Hi, this is Bruce Robinson with the DOPPS program, and thank you all for joining our activity this afternoon. We do appreciate your attendance. We have a wonderful panel of nephrologists, nurses, and patients as well to talk about COVID-19 and chronic dialysis, where we are and what's ahead for us. Next slide, please. All right, I'd like to begin by giving a warm thanks to our industry sponsors as well as public agency sponsors, as noted here, who provide support without restriction on our publications. Thank you very much. Next. All right, the DOPPS program is in our 24th year, and we're currently very active in 19 countries worldwide, 34,000 patients across non-dialysis CKD as well as HD and PD. Next slide. Principally, we're really focused here on our U.S. audience, and I have a screenshot here of our U.S. DOPPS Practice Monitor. The DOPPS Practice Monitor has been in existence for nearly 10 years, and with this program, we aim to provide very up-to-date trends in in-center hemodialysis care, which we do update twice yearly. The last this was updated was early March. We have webinars twice a year soon after those updates. This time around, because the update occurred in early March, it was actually just before COVID became a major issue here in the U.S. And our decision with respect to this webinar was to focus on where everyone's thoughts are, which is the COVID pandemic itself. As a result, the webinar today will move away really from direct presentation of results from the practice monitor. We will update in the coming months, specifically with respect to care observed, any changes in care post-COVID. Next slide, please. All right, so the topic for today really focuses on management of patients on chronic dialysis. We're not focused at all on AKI, nor on transplant patients. We'll touch base briefly on, I'll ask the panelists to give some insights into, first of all, what we know about infection rates and outcomes, and then care for patients who are COVID positive or sort of post-COVID patients. And then spend some time thinking about dialysis unit practices. Not much time on infection control. There's been so much out there, infection control and prevention. There's so much out there already. But more on testing, whether there have been changes in particular to the provision of in-center dialysis, some thoughts about home dialysis and its role, and then staff. How are things going with staff and really assuring that we have clear perspective from staff members as well. Finishing up with lessons learned, coming challenges, and the potential for long-term changes. Next slide, please. So we would love to have input from the audience. So we do encourage you to use the Q&A function. This is available to you for you to use throughout the meeting on the left side of your screen. Once again, please submit questions or comments as they may arise. And our facilitators are ready to go, and we'll triage and address those questions as best we can. So thanks. Next slide. We're also on Twitter, so feel free to join the Twitterverse as well. Thank you. Next slide. Okay, just wanted to give a little bit of very brief introductory comments, and hopefully we'll be done with this in 5 minutes or so as you transition to the panel. This is a screenshot from the Hopkins website that you all are likely aware of. It's such an incredible tool that we have actually updated daily. I'm showing data here from 1 month ago. And what I think with respect to impact on the population overall, I think perhaps deaths per 100,000 population is perhaps the most important metric we can follow to understand the impact of COVID overall. And what I did here is actually put stars by 15 of our DOPPS countries divided into three groups. The first is Europe, which is in blue, and then we have the Americas in red, North and South American countries, and followed by Asia in green. And it's really impressive to note that the death rate per million or per 100,000 population is highest in European countries. That said, it is very high in the U.S., where I've got an arrow pointed to the U.S., Canada, Brazil's rising rapidly as well. And really impressive is the very low mortality rates on a per population basis that we see in Asia, much lower than here or in Europe. And next slide, please. I wanted to also bring attention to this slide, which has been in the public press over the last week or so. This is showing the number of new cases per day in the U.S. compared to Europe. And Europe was, of course, at a terribly difficult time earlier on, but they've done very well, and we see the number of cases per day has fallen dramatically. U.S. had a difficult time early on, but unfortunately it's getting yet worse, and all of you have been aware of this worsening situation that we're facing here in the States. And I really consider this, I'm sort of saddened and quite discouraged by how we've performed overall as a country, and so much of this is really in the public health and personal responsibility realm with respect to infection control and identification. So, distancing, masking, and then identification, isolation, contact tracing, all of these areas that fall in the public health and public health responsibility space, which is noted in many Asian countries. They've done so well with this, and the Europeans are starting to do much better, and we still have a long ways to go. And as a result of that, we here in the States are faced with some important challenges, and those of us who take care of dialysis patients in particular are going to be faced with the results of this situation really head on. So in many ways, this webinar today, we brought together folks who've been in the midst of the early phases of that pandemic and have really important insights, and hopefully can provide insights to those who are starting to face much more substantial burden now in other parts of the country. Next slide. I had just a few slides showing DOPPS data. This is actually medical director survey data that we sent around the world, actually. Just wanted to show a couple slides to indicate variation in observed experiences as well as practices amongst care providers. And here, we actually have quite a good number of surveys back from China as well as from Europe. We don't have much from the U.S., actually fewer than 10 back from the U.S., but I did want to just bring up this data just to illustrate some variation in care here. The first slide is does session length or frequency, has that changed because of the pandemic? And we have 14% of American respondents, actually just 1 in 7, say that indeed they've actually shortened treatment because of COVID. Next slide, please. And then is the observation the patients are skipping treatment because of COVID? And actually about a third of U.S. respondents said that seems to be what they've seen. We'll get back to this later in the hour and bring in some sort of counter perspective to this as well. Next slide. Is there a shortage of staff at your clinic during the pandemic? And basically the top two bars in orange and blue add up to around a quarter. So around a quarter of respondents tell us that they've had shortages or had shortages that were made up through bringing in staff from the outside. Next slide. And you all have heard about and struggled with issues of vascular access procedures. Are you having difficulty obtaining vascular access procedures during the pandemic? And roughly half, or exactly half of U.S. respondents said yes, indeed, they're having issues with this. Hopefully that's improved somewhat, but that's another topic we can speak to. Next slide, please. Okay, and the last of these, are you more likely to recommend home dialysis because of COVID? And indeed, you see that over half of the U.S. respondents said yes. either for new and/or existing patients. And again, we'll get to this over the course of the hour. Next slide, please. All right, so the panelists today, again, I so appreciate you all for joining us today. We have actually 9 panelists with us today. Lori Amburn, to begin with, who is a nurse and a clinician education manager at Greenfield Health Systems, works with both the acute and chronic dialysis service, and also including the home dialysis service as well. Yeah, so thank you, Lori. Next. All right, and Kathy is also a nurse with Henry Ford Hospital and the Ford Health Systems, also works as an administrative manager, but lengthy history working with both the acute and chronic dialysis service. Okay, and actually Jason Hood at the last minute was not able to attend, but in his place, Janice Omri, thank you, Janice, for joining. Also as a nurse and home program manager at Northwest Kidney Centers, lengthy experience in particular with the home dialysis and and hemodialysis and home hemo in particular. But thank you, Janice, for joining at last minute. Next, please. All right, we're fortunate to have a patient with us as well, and Mark Johnson, we really appreciate your joining as you have. Currently in-center hemodialysis patient. And Mark, over the years, has done a lot of work in advocacy, served on the Kidney Patient Advisory Council, the Forum of ESRD Networks. You've done work before with the American Kidney Fund, with AAKP, and also with Network 12. So thank you so very much, Mark. Next, please. Jeff Pearl, a good colleague of ours, leads our PDOPPS study here, but also an associate professor at St. Mike's Hospital and University of Toronto in Canada. Jeff is very, very involved with ASN's COVID-19 response team and chairs its actually home dialysis subcommittee for that. Next, Rachel Perlman, also a good colleague of ours, works here at the University of Michigan, very lengthy experience working in particular, well, with our dialysis patients, but in particular our home dialysis program, which is quite a robust program here at U of M. Next slide. Okay, Vesh Srivatana works at Rogerson, also a nephrologist and in charge of the peritoneal dialysis program at Rogerson. Rogerson's an important and very innovative nonprofit dialysis provider located in the New York City area. So thanks, Vash. And next we have Suzanne Watnick. Suzanne is Chief Medical Officer at Northwest Kidney Centers and Professor of Medicine at the University of Washington. And NKC is also a very innovative dialysis provider here as well. So it's just great to have Suzanne with us. And Suzanne's been very involved nationally as well with respect to COVID response. And of course, NKC, given its location in Seattle, was very closely involved in the early COVID experience. And lastly, Jerry Yee. Jerry Yee, who's Division Head of Nephrology and Hypertension at Henry Ford Hospital. And Jerry's really well known as an outstanding clinician, researcher, teacher, winner as well of the Donald Selden Award from National Kidney Foundation last year. So next slide, please. All right, so those are our 9 panelists. And as we launch into the panel discussion, I have just a couple preliminary thoughts here on this is actually a slide from the CASER, which is a collection of data from that's produced by the networks. And Jeff Pearl actually presented this a bit over a month ago. A couple points to make here. Number one is that the mortality rate, at least presented here based on CASER data among dialysis patients, is about 11%. And a second point to note from these data is that, just extrapolating from what I see in these data, is that infection rates among the home dialysis patients is quite a bit lower than in-center hemo, probably about 1/4 what we see for in-center hemo. If you keep those points in mind, then the next slide. All right, these are data that have come out from the CMS just quite recently with data for encounters through the middle of May. And what we see from CMS is that the number you see in red, 2614 ESRD COVID cases, and that's roughly, let's say, 2.5% of patients with ESRD. And this compares to, in the numbers just below, about 0.5% for other Medicare beneficiaries. So clearly, ESRD patients are becoming infected with COVID at substantially higher rates than others. And if we look at the slide just below, it looks at hospitalization rate, and just 1341 over 2614 is roughly 50%. So roughly 50% of patients with ESRD with COVID are hospitalized for that condition. Next slide, please. Okay, and then moving on to thoughts for the panelists. So what I did was present some. I mean, we really ultimately don't have enough data yet, do we? But I presented a bit of data on infection prevalence among chronic dialysis patients, and a little bit of data on outcomes as well. Just wondering for folks if you have any additional comments on this. And for example, do we think that transmission is declining among in-center hemodialysis patients? Susanna, I think you had given some thought to this, but just interested in your thoughts.
Well, that's a question that doesn't have a single answer. So as you alluded to, there were certain areas where this was hit first. Seattle certainly was one. And for us, rates have actually continued to climb at a relatively linear fashion. However, I know in the Northeast, for example, there really was quite a rash of COVID cases, and that has really quieted down, but in its place, locations in Texas and Florida and Arizona have increased. So overall, it continues to climb, but again, depending on what the state of the outbreak is in that geographic location, things have either continued to climb, ballooned, or quieted based on that. And it really does follow what the general population is seeing. By far and away, what we do see is that it affects individuals in skilled nursing facilities and group home settings disproportionately to other patients, and also patients from particularly socioeconomically disadvantaged, or certain, and there are certain predispositions with those with suffering from disparities in the country have also seen higher rates. Does that answer your question, Bruce?
Oh, no, it's great. And I guess a question that I have, quite specifically is, just as, for example, rates of infection are higher in skilled nursing facility patients than others, are rates of infection higher in hemodialysis, or in particular in-center hemodialysis patients compared to, for example, home dialysis? And how strong are the data one way or another?
So the data hasn't been fully collected, but certainly anecdotally from many dialysis organizations around the country, patients on in-center hemodialysis are disproportionately affected in comparison to those receiving home dialysis, which is not surprising. However, many dialysis organizations have really not seen transmission within the facilities. Another interesting thing which CDC has noted again and again, and they have asked themselves, why is it that we're not seeing as much transmission as we would have figured in the dialysis organizations themselves? So that's a question with probably an evolving answer.
Indeed, right. Yeah, my sense is as well that really good work is being done to limit that transmission, and you, of course, Suzanne, have been right at the forefront of this. But my sense is that is occurring, and so ultimately, what is the differential rate of infection for in-center dialysis versus a really good control, which is home dialysis patients? I think we have yet to see still, though I agree it does seem that infections are somewhat higher based on preliminary data.
It's Jeff here.
Yeah.
The other thing, as we look at this data in the future, and it certainly is a question on my mind, and I agree with what Suzanne has said, is also the testing rates in center patients versus home. So we know that this disease is a variable in its presentation and severity, and so at least in my unit, we've been doing a lot more testing, and we've been finding a lot more asymptomatic COVID-19 positive in-center patients, whereas we would never think to test an asymptomatic home dialysis patient because, of course, they're doing well and they're at home. So it's another thing to think about as we look at modality-specific rates in the future is, are we case finding more in-center than home?
Yeah, it's an excellent point. Excellent, yeah. There was a question from the audience, and Jeff, perhaps you could take this. It actually relates to what we showed on the on slide 24, is the 2614 ESRD patients for the who are SARS-CoV positive, is that for the entire U.S.? I think. Oh, sorry.
It is.
The next slide, slide 25.
Oh.
Yep, 2614. Yeah.
So this.
That's actually per 100,000 beneficiaries. Yeah. So Medicare beneficiaries on ESRD per 100K, and there's roughly 500,000 total. So you multiply that by 5 to give the total count roughly. Total count in the range of 10 to 12,000, I would estimate. Actually, pardon me, this is ESRD, which I would assume includes transplant, and then we're talking more like 700,000. So, yeah. Okay, next slide, please. 26. Thanks. All right, just moving on. Next slide, 27. Thank you. Okay, good. So a couple slides are questions about patients who, either chronic dialysis patients who have COVID or perhaps recovering from COVID. Where are we with respect to cohort COVID shifts and cohorting of such patients? And in particular, the question that has come and people have been talking about of late is what to do with persistently positive tests. What do they mean, and how do we manage cohorting in that setting? Suzanne, do you want to speak to that as well, based on your thoughts?
Yes, absolutely. We address this nearly every day. So in terms of recovery, we still don't know exactly what the course of recovery looks like for the average person in this country, but even more so for patients on dialysis given their immune system. And what we've been noticing, so for the dialysis organizations that use a test-based strategy to try to bring patients back from a cohorted COVID-19 clinic, for example, the CDC requirement would be that you'd have 2 negative tests at least 24 hours apart. The other strategy would be a time-based, which they say is 10 days. So what a lot of dialysis organizations have noticed is that there are many patients that remain positive after 2 weeks. One large dialysis organization yesterday quoted a rate of 25% of their patients were persistently positive past 2 weeks. And that raises a lot of challenges because we don't know if those folks are still infected and are able to transmit. So what I can say is that the CDC is standing up a study because the question is, what is the natural history of PCR positivity in dialysis patients who are recovering from COVID-19, and what point in recovery can they be considered non-infectious based on negative viral culture potentially? So we don't know the answer, but within the next 2 to 3 weeks, there is a study that the CDC will begin that should last approximately 7 weeks, where they're going to be collecting serial samples twice a week for the first 3 weeks and then weekly for the last 3 weeks, not just RT-PCR, but also sputum, doing antigen tests on the samples and blood, and then doing viral cultures to see if those cultures remain positive. So although we don't have the answer yet, at least we will have more data in a reasonable way, probably within about 3 to 4 months, if we're able to get preliminary results. Nonetheless, that doesn't help us in the very short term, and so what do you do? For those of us that are getting positive tests, we don't feel it's right to let those folks with a persistently positive test back into the general population, and so I don't know of any dialysis organizations that are doing that right now. Conversely, for those that do have a time-based strategy, many dialysis organizations are not following the 10-day CDC rule, but rather are using 14 to 21 days to allow patients who have tested positive, have had no symptoms, and then are waiting that period of time.
Great. Yeah, thank you, Suzanne. In the interest of time, let me. The next comment relates to vascular access, and actually, just wanted to ask Vasundara Srivatana to speak to this. I know you've had at least some experience here with use of acute PD for. I think this is for your chronic patients who become clotted. Do you want to speak to that?
Yes, this is Vasundara Srivatana. Can you hear me?
Yes, thanks.
Great. So on this issue, in I'll say the peak of the pandemic, we were experiencing a lot of clotting. This is the chronic patients that were inpatient of vascular access, more or less no matter what kind of anticoagulant we were using. So we did convert a handful of patients to PD. That posed a lot of challenges both acutely and chronically in transition of care, but we literally had no choice because of the access issues. So if I have something to advocate for is that having the ability to open this capability of either urgent start or acute PD for usage in converting patients if you really need to, or really critically ill patients with AKI, and just having the option open gives the nephrologist a lot more flexibility. So we did have a handful of patients that needed to convert, and it remains a challenge because these are probably at its core not the best home dialysis or PD patients, and yet we had no access. So we have to work it out case by case.
Right, Vash. Yeah, so in this case, you found that very useful to have that capability at least. So this will also be fascinating to see to what extent this is actually occurring out there, across the country. To a large extent here, we're speaking to the choir, particularly among the panelists. All of you have tremendous experience with the use of PP. As you know, that's not the case often throughout much of the country. And one other comment on this slide, I mentioned outside the U.S. I mean, we've read and I've spoken to individuals in our work where policies have essentially been implemented where, acutely ill chronic dialysis patients are not, for example, admitted to the ICU or offered acute dialysis in the acute setting. And this is due principally to resource constraints. And there are some publications starting to come out there with respect to this. This doesn't appear to be the case here in the States, where I think really much more is that a goals of a care-focused approach involving the patient in those sorts of and family in those sorts of decisions. Right. If we could go to the next slide, please. Here, still in the realm of post-COVID care. And Vash, I think you had some interesting thoughts about this as well. You noted challenges with respect to transitioning folks out of the hospital.
Right. This is Vasundara Srivatana again. So this is, it's difficult to have a patient on dialysis placed in a skilled nursing facility, I would say, before COVID. So with COVID, as it evolved, there were very rapidly changing policies, probably daily, where some facilities were accepting COVID patients, others were not. Governmental orders were put down so that in New York, at least, that they had to start accepting patients. That evolved over time, and so that they had to have strict testing policies. And so the skilled nursing facilities with dialysis on site were hard to find to begin with, and then these type of policies made it even more difficult. As an extension, in my experience, is that looking for someone who could do PD on site was even more rare. The workaround locally was to build COVID-positive rehab sections of the hospital or rehab units, and that relieved some of this burden because we could utilize some of our existing dialysis capability on site in the hospital to provide chronic dialysis for these patients. So that helped relieve some of this in terms of the transition. I want to also tackle the clotting issue. I would agree that during the acute phase of the critical illness, during the cytokine storm, the clotting is the worst, absolutely, to the point where you're clotting through heparin full-dose anticoagulation. But anecdotally, again here, I think this remains to be seen, but we've noticed some late presentations of DVTs as well, and it's hard to say if that's immobilization, if it had to do with COVID directly. I think it would be hard to say.
Indeed, Vesh, thank you. That was actually your last comment in response to a question from or comment from the audience. That clotting may be most likely secondary to cytokine storm and not seen in mild disease per se. If we go to the next slide, right, this is actually another question we got from the audience that again relates to the issue of clotting, and we certainly don't have clear answers here. Jeff Pearl, do you want to just speak briefly to this particular question? Jeff, you might be on mute.
Sorry. So, can you hear me?
Yes, thanks.
Okay. Yeah, so I think it's sort of a corollary to what Vesh said already about the coagulopathy with COVID. And so we know early on there's a high fibrinogen, elevated D-dimers, and that both increases the risk of mortality related to COVID, but also is a prognosticator in terms of the coagulation problems that will ensue. And to the question about cytokines, certainly we know that increasing IL-6 levels associate with higher levels of fibrinogen in some of the research that's out there. And so I guess a more ambiguous area is whether these long-term clotting problems persist. And so I don't think that we know the answer to that, and so I don't know that we would necessarily monitor as a result in patients who are recovering from COVID, perhaps particularly in those that haven't had clotting issues, but in those that have, there's certainly, in preparation for the roundtable discussion, I did ask one of our clotting specialists at my hospital, and she said we really don't know if it lingers on after the recovery, and there's certainly several NIH trials that are going to be underway to assess the utility of antithrombotic therapy, both in the pre-acute and post-hospitalization patients. So I don't know that I have an answer, but certainly I wouldn't advocate for routine monitoring based on what we know right now.
Yeah, indeed. Right, Jeff, thank you. And again, as you note, a lot of work underway and important studies underway in this space, as well as for example, Suzanne just noted, to follow-up positivity testing. So there's a lot going on, and a lot more we'll know, hopefully, in fairly short order. Next slide. Next slide, we're going to. So we decided not to focus on symptom screening, masking, cleaning. These are all absolutely critical. There's a lot of great information out there. I would note that Suzanne, I looked at a nice presentation that you led. Which commented, follow the science, insist on the highest standards of care for our patients, whether or not they have COVID, and certainly utilize available resources. There's a lot out there. We have a slide at the end with links, but CDC, ASN, and others have wonderful resources out there. So I don't think we'll spend any more time on these issues. Next slide, please. All right, this is a question of real interest to folks related to testing for SARS-CoV status, whether with respect to PCR and or antibody. Jerry Yee, do you have any comments on sort of where your group is with?
Thank you, Bruce. Thanks for the ability to participate. We first retrospectively noticed that we had high ferritins in the level in the patient population before we actually had our peak in incidence of admissions to the hospital. We had 111 cases out of about 1,950 patients. We had about 58 PUIs. That's 111 deaths, that is. And so some of those PUIs are obviously deaths from COVID that were negative testing. We've gone through different rounds of testing, different types of PCR. We have our own PCR labs here. We're very fortunate in that, but you're only as good as the reagents that you get. So everybody's numbers are down. Recently, we have obtained more tests, and through a grant in the city, we have a couple of units, about 7 large units, which means 100 or more, and 3 of them were tested universally. However, I cannot give you at the time how many patients said, I will do the test, and I don't have the results yet, but we will transmit those to you. So the city wanted to first screen patients with low social determinants of health. We have a city that's 88% African American, and that's reflected in the dialysis unit. So they said, let's screen the dialysis units together. The infectious disease and infection control people were all over this. They asked us, we said yes. We're also engaged in an antibody testing program with a company that has received a lot of press, but we can't name which one, and that trial is undergoing, but we will give you the results of our positivity rate. One other thing that we found, and you know that in hemodialysis medicine, that the patients and the healthcare workers have a greater bond than that which you might see in other types of internal medicine divisions and specialties. And people talk to each other a lot, and we found out one of our problems was it's lunchtime. If people eat lunchtime at the same time, and to Suzanne's statement that we don't have a lot of evidence that patient to staff or patient to patient transmission has occurred, we think we had a lot of staff to staff transmission eating lunch, and so we took very strict preventive measures to have people staggered for lunch and 6 feet away and all that sort of thing. And Michigan is going through a semi 1.5 wave right now, along with the rest of the United States. So all these things are being enforced. And thank you for the question.
Yeah, Jerry, thanks. Yeah, I think you noted relatively high SARS-CoV-2 positivity among staff. It sounds like some of that occurred quite early, and you all have taken steps to hopefully reduce that.
Yeah, it's Jeff here. I just want to echo what Jerry said. We had an outbreak in our hemodialysis clinic, and certainly lunchtime and staff-to-staff transmission was a very important factor. So I just want to echo those comments and their importance.
Any other comments on that from folks? Suzanne, you had noted as well that as you followed this, there have been so far even a number of very different approaches taken amongst the different dialysis organizations with respect to testing to date in the absence of...
Yeah, thanks, Bruce. Important question. This is Suzanne. So there are different strategies, but there are very few locations where they're doing universal testing. So it's nice to hear about, Jerry, your experience, probably from a hospital-based system. But unless there's been an outbreak in a specific facility, for the most part, testing has been amongst those who have either been symptomatic in the facility, or if they've gotten tested randomly going in for a procedure and have been asymptomatic. That's how we've been finding out a lot. But one of the very hot topics right now, thinking about the future of testing in the dialysis organizations, is thinking about influenza season. So a number of groups are talking about, can we coordinate both COVID and influenza testing come the autumn? And there are tests out there that with one swab, although it needs to be run on 2 machines, you can do both testing for COVID and influenza and potentially impact and treat influenza cases earlier on, which might be a silver lining overall.
Bruce, if I may interject, Jerry Yee again. As I said, one of our dietitians actually picked up on this ferritin idea, and we track ferritins. Then after that, there's the ability for our data analysts to track temperature. So we actually made a plot of everybody's temperature for 7 weeks and graphed them, and we could tell in which units we were going to have problems. Suzanne rightly states, if you don't have the swabs and the testing, you can't do much about it. So for many weeks, we felt like there's a problem here, but we can't do anything about it. And I implore healthcare systems that they really need to look at the ESRD patients much more carefully than surgery patients and anesthesiologists, because they cancel all those procedures anyhow.
Right.
Bruce, it's Rachel. If I could squeeze in one thing about this also. I'm at another hospital-affiliated dialysis unit, and we have not had the ability to test all of our patients, even though our hospital is similarly doing its own testing and has a highly functioning lab. And so for people who are at a different, an earlier stage in this pandemic, thinking about that capacity for your dialysis units ahead of time, because it's something that I certainly am a little jealous to hear that you were able to do that at Henry Ford.
And you're saying, Rachel, this is at University of Michigan at the outpatient dialysis unit. It's just
correct.
You don't have capacity or access to testing?
Initially there wasn't capacity, and now we don't have a mechanism or an arrangement with our lab, and so we have sent people for testing who are symptomatic or, like Jerry said, who had another reason to get tested, like going in for a procedure, which is getting more common now. But we definitely have not had a way, aside from temperatures and symptoms, to screen our patients.
Yeah, so this remains critical, doesn't it? Really impressive. We had a couple
Jerry,
of interesting comments. Yeah,
sorry.
Jeff,
I was going to say, Jerry, there's a really...
Go ahead, Jeff, yeah.
Yes, I'm listening.
Sorry, I was going to say, Jerry, there's a follow-up question to your comment about contact tracing among the positive patients, and is that going to be done?
Let's see. Lori, are you on the phone?
I am. If you could repeat the question, that would be fabulous.
Yeah, so there's a question about whether contact tracing is being done among patients on hemodialysis who test positive.
Actually, we early on in the process, we were doing some contact tracing, and public health did contact one of our dialysis facilities with one of our first patients to do a little bit of contact tracing. So public health is handling that, but as it got more community-wide spread in Southeast Michigan, basically 3 counties in Southeast Michigan were very hard hit. That contact tracing, because it was community spread, because our patients don't live at the dialysis facility, they told us to stop doing contact tracing because we wouldn't know if they got it in the community, if they went to an event, or anything like that. Now that it's slowed down a little bit, not as crazy as it was in March and April, we are looking at starting to do contact tracing again, at least within our dialysis facility. So looking at if a patient tested positive or showed symptoms today, we would look back 2 days to see who were the team members that took care of them, who were the patients that sat near them, and then start to do some screening and symptomatology and talking to the patients. There's really good information on both CDC for contact tracing and on Michigan Department of Health and Human Services. And they even go through at the different stages, when is it good, and then when it becomes too widespread, you really can't do good contact tracing. So it has varied over time, and we'll start doing that again. I hope that helps answer the question.
And this is Suzanne. I want to add one more comment to Holly's question. So we have been doing contact tracing for every one of our patients who've been positive, and it's really been quite illuminating because we have seen chains, and we've actually discovered other people who've gotten tested and, importantly, went into quarantine as a result of that. And it also confirmed what a lot of us around the country have been seeing, that transmission within the dialysis facilities has not really been happening. It's been happening in group settings and out in the community. And we've been supported, just like the person from Henry Ford mentioned, by our local county public health folks and the CDC.
Right. And we actually had earlier another comment from the audience with the observation that indeed, the transmission is occurring outside of the dialysis setting per se, and not so much within the hemodialysis space. And Suzanne, there you're talking about contact tracing across sort of at the community health level, which is wonderful. And then, as Lori noted, the issues with sort of implementing that, particularly in the context of very high.
So maybe I'll ask Suzanne first, and maybe some of the other panelists can answer. If there's a question here that if universal testing of dialysis patients were to be implemented, maybe I'll back up and say, should it be implemented if we have more access to testing? And were it to be implemented, how would we go about employing that kind of a practice?
Well, I think really the important part of that question is the first phrase. If
right.
testing were to be implemented. And this discussion has been going on for 3.5 months amongst many of us in this sphere. And the question is, if you test all of your patients, what does that mean on Monday if they're tested, and then you look at Friday? And so the logistics of testing, we can set this up ourselves, we can bill for it, but in terms of setting up contracts and paying for transportation, it's additional, is it providing additional value? And so we don't have an answer for this. This looks like it's from Holly Kramer. But if we were to implement this, what I would say is you probably need to do this on a weekly basis from what our discussions with the county public health have been. And if you look at the CDC study that's coming up, again, they kind of feel like weekly testing would be the way to go. And that is really, that's a task on top of all the things that your dialysis techs and nurses do that would be quite gargantuan. So I'll leave it at that.
I think in the interest of time, it's a wonderful discussion. I think I could focus the final, we have 13 minutes on, first of all, I'd love to hear more from the dialysis staff perspective, which is actually the next question. And then also really want to touch on some high-level thoughts on home dialysis, telemedicine, et cetera. So if I could ask our nurses to jump in, and Janice actually from Northwest Kidney Centers, do you have any quick thoughts on this? So I've listed on the slide, how's morale doing overall? How are folks feeling about safety and approaches to testing, and then also resourcing issues?
Hi, this is Jen. I oversee the home department, and I think morale is pretty good. I think initially everyone was scrambling, as Suzanne said, to come up with protocols and procedures, but we were quick to organize our clinics and do telehealth for our home patients so that we have minimized their exposure to the in-center units.
Hi, this is Lori Amber with Henry Ford.
Thanks.
I got onto that. We had to do similar things on scrambling in the beginning at our in-center hemodialysis units and our home units and our acute units, to go along with all the changing guidelines. I think staff knew we were working hard at that, and communication was key to let them know, and talking to the various areas every single day and having leaders around to keep them up on the newest policies and the newest changing guidelines to keep everyone safe. And I do think now they definitely feel they've seen the limits for the exposure and feel better. Did they go through saying, what the heck just happened here? And a lot of, some of our teams had COVID at home as well with family members, yet they still had to come in and then take care of patients with it and deal with it. So there's lots of stress at that time. I think some of that is eased up with still concerns for the future. And then on the rotating our resourcing of staff, a creative approach that did come up was some of our other clinics obviously shut down because they were non-essential services or non-emergent services. So for those people that got put off on either a furlough or something like that, we were able to get some nurses redeployed and some medical assistants redeployed that helped with assessment and med pass in some of our areas and or screening our patients in the lobby so that our dialysis skilled staff could focus on doing the dialysis treatment itself. So that did help with some of our staffing issues.
This is Kathy Bernardelli as well from the Henry Ford system. So I spent most of my time in the acute area. What I found out is staff were getting sick. We were up to the point of over 40% of our acute staff that were off ill with COVID. So it was a true challenge to get through all the needs of how to care for patients. So we did a multitude of juggling of schedules, juggling of treatment times of our continuous treatments and dividing them up to two 10 hours and splitting people. But the biggest thing I found out was the staff truly was scared because the person they worked with on Monday now is off on Wednesday and they tested positive and they were scared for themselves. And I think it helped when we did a couple things. We brought in infection control to do a separate in-service for them, and they spent a great deal of time with them and allayed their fears. It was wonderful what they did. And we also brought in, I picked up a few baby monitors because we had so many treatments that were in regular treatment rooms, patient rooms, that they were wooden doors, so you couldn't see. And the team members would have to sit in a room for their bedside treatment. So we got some baby monitors that could be panoramic, so they were able to sit outside the door, but yet rotate the monitor to watch the patient and the machine. And that helped tremendously on them feeling that they were being heard, their needs were being addressed, and they did much better with that. And on the financial side, we actually did a bonus for the team members as an organization during this very, very peak time because they were stressed. They were working 18, 19-hour days and coming back the next days, and we did everything we could to thank them. And like Lori talked about is leadership, being on site, talking to them, being present, and just saying thank you and thank you and thank you again.
Yeah, Kathy and Noel, thank you so very much. And yeah, it's amazing. Being able to communicate and feeling heard and getting key questions addressed is so important. And again, for folks elsewhere in the country who are starting to face this a surge, perhaps for the first time, this sort of experience is hopefully so useful to hear. I would like to get perspective from Mark Johnson, our in-center dialysis patient. And Mark, we really do appreciate your joining. Do you have any thoughts for us?
Yeah, can you hear me?
Yes, thank you, Mark.
Okay. From the patient perspective, I come from a very small unit, which is only 2 staff members. And so far, they've been able to rotate in and out in order to give them time off. Our biggest concern as patients, I think, is that if COVID became even more prevalent and even really spiked to where staff is really starting to be affected by being exposed, what happens to the smaller units? If you only have one person, or if you have only 2 techs but no nurse, we can't operate. I know we've had a lot of problems with our times being changed. So far at our unit, that has not been a problem. Everyone seems to cooperate. However, I do know dealing with the network, and it's a 4-state network, that's probably one of the biggest complaints that patients do have is that their times are being changed quite often. Also, the wearing of the mask is understood, but one of the big problems that probably leads to involuntary discharge from a lot of the patients that we've seen have been that they can't eat during dialysis anymore. And I think it needs to be explained better by the staff why this is necessary to do. In fact, I think after the pandemic is over, most likely we're still going to need to wear the mask and still not being able to eat. These are just practical things from the patient's point of view.
Mark, thank you. Any comments from other panelists in response to Mark?
Hi, this is Lori with Henry Ford again. Mark, you make extremely good, valid points. It's been hard for the patients to do that and to sit with the mask there, and it's incredibly important that we do explain, like you're saying, why it's so important that they don't eat while they're on treatment and keep the mask on to keep themselves safe and others safe. I know early on we had patients that were kind of scared to answer the screening questions truthfully, and then they would finally tell the team member that they've known for years a little bit more once they felt more comfortable. So I do think that's really important. We think about it from the patient perspective and try to communicate the safety of it all and that we're here to help keep you safe.
Absolutely, Mark. Thank you again for those comments. And again, as we, so some of the topics that we end up focusing on here on the medical side may be really quite different from the specific concerns that you and other patients may have. But once again, communication absolutely critical. And I do think, again, in reading some of the work that's come out there from folks on the line here who've been at the front of this, with a real focus on the need to communicate, both across the administration, different hospital services, but also amongst different staff, and in particular with communicating clearly, being transparent. These are critical. I have a slide up here. We had a slide up here speaking to lessons learned, sort of as we wrap up. We're down to just a couple minutes, but just wanted to, with this slide up, just wanted folks perhaps to give any quick thoughts on home dialysis, where we might be moving with respect to home dialysis. Has COVID moved the needle at all? Jeff, do you want to start that?
Yeah, thanks, Bruce. I think we've all realized now that that if patients, patients certainly for purposes of social distancing and for many other logistical reasons, I've been less concerned and less worried about my home dialysis patients than I have in many ways of my in-center patients who are coming to clinic 3 times a week. And, unfortunately, there was a comment in the panel about differences in practices that are inconsistent perhaps across clinics that might be invariably enforced. And so I think for me, and I'd be interested to hear what other people think, I think it's a wake-up call about trying to encourage and promote the use of home dialysis. And there's certainly, unfortunately, a very strong benefit in the context of COVID-19. And I say unfortunately because we all wish we weren't in this situation, but we are, which is to allow patients to receive treatment in the safety of their own home. And in general, I think the lesson learned for COVID-19 is that there's a lot of advantages to home-based care in many aspects of medicine, and we have a viable alternative therapy for our patients that we can do at home. And, this is riding on the coattails of the AAKH initiative, which certainly, in principle, is seeking to grow home dialysis. And so I think this is a wake-up call for us all. I don't think that the infrastructure and all that's needed to grow home is necessarily there yet and was there yet before COVID. And I think that's why we're all a little bit struggling. But I think COVID should be the sort of proverbial swift kick that we all need to make resources and make education more broadly available to all patients and all providers so that we can increase the use of home in patients who would be appropriate for it.
Jeff, thanks. This of course, will be absolutely fascinating moving forward, and hopefully it will lead to indeed a true paradigm shift. We have, with actually just a minute to go, there's another comment from the audience from a patient, actually, formerly in-center hemo patient, but still an ESKD patient. And actually, she spoke to much of what Mark said, which is that she has concerns that the satellite facility not following methods perhaps that are being implemented centrally, this again speaks, I think, to smaller sites, and might patients really be at risk at smaller sites as resources are challenging. She notes that some of the staff can be frightening to patients. And as well, just as Mark noted, schedule shifting has been very, very challenging. So patients often aren't given a voice when schedules are changed. They may be changed quickly without much notice. And then a big complaint about transportation. We didn't get to that today, but everybody knows on the line this has been a big issue as we've talked about transporting. And in this case in particular, transport drivers leaving patients for hours after their treatment. Any quick comments on that as we wrap things up from the panel with respect to hearing this from patients?
Hey, this is Rachel. I'd love to add one quick thing. Which is, as I was meeting and counseling folks who were approaching needing dialysis during this pandemic, I felt like PD was much more intuitive and almost an easier thing for them to be interested in, because the desire to be at home and not coming in so often felt more palpable, and the benefits of being at home almost didn't, of course we went over them, but almost didn't need to be explained because everybody was focused on being at home. And so it was a very easy time to stimulate interest in PD, and it's not clear how much that'll be sustained, but I felt like the idea of PD was really very appealing to folks who were approaching dialysis.
Absolutely. Thank you, Rachel. So again, as we're past the top of the hour, Christy, if you could go just 2 slides earlier. Okay, just a note, once again, there are tremendous resources out there, and I have great thanks to all those folks who've been involved with these sorts of resources, some of which are listed here and the folks are aware of. There are others as well, but please take advantage of those. Next slide. We will be posting this at the Arbor Research website on our YouTube channel, so that will be available. And next slide, please. DOPPS, final slide. DOPPS Practice Monitor will have its next webinar in 6 months. There are actually a host of other questions from the audience that we didn't have time to get to, and we'll do our very best to respond to those offline as well. So with that, I'd like to give a warm thanks again to the panelists, to our patients, Mark, as well as those online and who submitted questions, as well as to other participants. All right, thank you very much. Bye-bye.
Thank you.
Thanks, bye-bye.